Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. My name is Julia Gauci and I'm a gastro trainee in South East Scotland. Today we are going to be discussing PBC, and I'm delighted to welcome Dr Ruairi Lynch, a consultant hepatologist in Ninewells Hospital in Dundee. Welcome, Dr Lynch.
Hi, thanks for inviting me.
So it's probably worth kicking things off with a definition. Can you tell us what PBC stands for and what features characterise this disease?
So PBC stands for primary biliary cholangitis, and it's a disease, it's an autoimmune disease where there's a T-cell mediated destruction of bile ducts. And it's got multiple different etiological factors. It's not quite clear what the drivers are from it. There's environmental factors, such as geographical location can contribute to risk of PBC. Smoking, xenobiotics, infection is also thought to be related to it as well. But there's also genetic factors as well that play into PBC. Autoimmune diseases, it correlates with certain autoimmune diseases such as celiac disease, autoimmune thyroid disease, and also Sjogren's syndrome as well. And there's also familial links as well to suggest a genetic element to it as well, where females are daughters of female patients that have PBC are at increased risk of developing PBC. And there's also epigenetic features as well that cause it. And what happens is you get a T-cell driven mediated attack on the biliary epithelial cells. And this results in cholestasis and loss of the protective umbrella that surrounds the biliary epithelial cells, and therefore results in eventually in scarring and fibrosis. And that biliary cholestasis actually begets further injury as well.
Okay. And can you tell us a bit about the prevalence of PBC and who it tends to affect?
So PBC is termed a rare disease, and that's because its prevalence is lower than the benchmark for rare diseases, which is 50 per 100,000 population. The prevalence of PBC is estimated to be around 35 per 100,000 in Northern Europe and North America. It primarily affects females, so there's a 9-to-1 preponderance for females, and as such, with increasing age, it also is prevalent. Its prevalence goes up as well, and the median age at diagnosis is around actually 65. These two factors combined actually mean that patients that in the female population, the prevalence in patients over the age of 45 can be up to 1 in 800, so significantly higher than the general population prevalence. Interestingly, when you think about male patients, although there's a less frequent prevalence of PBC in males, they're more frequently diagnosed at a later date with more advanced disease. And this is probably because of diagnostic bias within the population, within us as medics, thinking that the male population are less likely to develop PBC, so it's not front and center in our mind. And also the PBC prevalence in males is actually changing as well. So certainly in Northern Europe, its prevalence is increasing in the general population, and in males particularly, there's data from Italy suggesting that, for example, prevalence is on the increase.
And how do we diagnose PBC?
So the majority of patients with PBC are asymptomatic. 50 to 60% of patients at diagnosis don't have symptoms. And for this reason, a lot of patients are diagnosed on incidental findings of abnormal liver function tests, such as patients who have had liver function tests done for another reason and are found to have an elevated alkaline phosphatase. The other thing to say is that some patients do obviously present with symptoms, and the most common presenting symptoms are fatigue and itch are the two most common. The other thing that's seen in patients with PBC is xanthelasma, so that's cholesterol deposits around the eye, and that is also a feature that some patients present with, although a smaller number. The primordial features associated with PBC from a biochemical point of view is an elevated alkaline phosphatase and a cholestatic picture to their liver function tests. And this is in patients where you see this and you've ruled out any other obvious causes, you need to start thinking about PBC as a potential diagnosis. People quite often wonder about gamma GT and its role in PBC, and actually there's no definitive evidence an isolated elevation in gamma GT is associated with PBC. And in fact, the role, according to the guidelines and what the clinical practice should be, is that gamma GT should be used as a confirmatory test for patients that are found to have an elevated alkaline phosphatase to confirm the biliary nature of the elevated alkaline phosphatase.
Okay. And what about serological markers? Are there any more specific tests for PBC?
So yes, so for patients with PBC, if you're suspecting PBC with abnormal liver function tests, I think the next two steps would be, one, to organise some abdominal imaging. So with ultrasound scan would be the first port of call to ensure there's no obvious biliary ductal dilatation. And then the next port of call is to ensure that patients have had a liver screen sent. Now, lots of doctors talk about sending liver screens and we kind of just send them away automatically, but it's important to know what the specific factors that we're looking for when we're thinking about PBC are. And that is a positive AMA or a PBC specific positive ANA. Now, previously when we analyse autoimmune tests, autoantibodies like AMA and ANA, they were done using immunofluorescence. And so the diagnosis was previously attained if you had a positive AMA by immunofluorescence, so anti-mitochondrial antibody, and the specific anti-nuclear antibodies that we looked at was, you looked at the staining pattern. So if they had a nuclear dot staining pattern or a rim-like membrane staining pattern, these are highly specific for PBC. So 95% of patients will have with PBC will have a positive AMA and with an M2 phenotype. And then when you're thinking about ANA, 30% of patients with PBC will have a positive ANA. And the two specific autoantigens that we're interested in that are now tested for using ELISA are the GP210 and the SP100. And these are the two you should, if you're getting an ELISA, you can get back these results. And if patients have positive ANA with those two autoantibodies positive, you can then make a firm diagnosis of PBC. And 95% of patients who have those specific ANA autoantibodies will have a diagnosis of PBC. And interestingly, within that 5% of patients that have an AMA positive result, a large proportion of them will have a positive ANA.
Okay. Now you mentioned imaging earlier and you mentioned abdominal ultrasound. Is a normal abdominal ultrasound enough to exclude alternative diagnoses when you've got somebody with a cholestatic picture on their liver enzymes?
So if you're you've got a normal abdominal ultrasound scan and you've got a cholestatic picture with these positive autoantibodies, then an ultrasound scan is sufficient, so long as you've ruled out any biliary dilatation, ductal stones or anything like that. Now, the other thing to keep in mind is if you have a clinical suspicion there's something else going on, you always have to investigate that further, but it's sufficient to make the diagnosis of PBC with cholestatic liver function tests, so raised alkaline phosphatase, the autoantibody profile, and the ultrasound scan that hasn't demonstrated another cause. MRCP is sometimes used, so that's more so in the patients where there's seronegative PBC, so that's the patients where we've got a strong suspicion of PBC, but we don't have the serological diagnosis, so we don't have a positive AMA or ANA. And in that population, I'd certainly arrange for them to have an MRCP to look for other diagnoses such as PSC. Interestingly, the one thing that you need to be careful of when you're requesting MRCPs in patients with PBC is that quite often they will demonstrate that they have lymphadenopathy, particularly at the portal hepatis, and this sometimes raises concern of malignancy, and this has to be weighed up with the clinical picture.
Is there any role for liver biopsy in the diagnosis or in the staging of PBC?
So liver biopsy is an interesting one when it comes to PBC. Certainly, if you have a patient who has a serological diagnosis of PBC, so the positive AMA or ANA and a cholestatic liver function test, then a biopsy is not required. And in fact, in studies of patients with early disease where biopsies were performed, 50% of patients with bona fide PBC were found to not have evidence of it on biopsy. Furthermore, biopsy in PBC has other issues because PBC can be a very heterogeneous disease within the liver. It's been shown in explants of patients who have been transplanted for PBC that all 4 stages of PBC have been seen on the explants in various different geographical regions. So you're not definitely assured that you're going to pick up an area of disease by doing a biopsy. I think the patients where biopsy should be reserved are for the patients where there is diagnostic uncertainty. So that would be the patients where we suspect PBC, they've had a normal MRCP, the serology is negative, and we want to affirm the diagnosis with a biopsy. The other group of patients where I think it would be interesting, it's useful to use, is patients where we've got a concern about autoimmune hepatitis overlap. So PBC autoimmune hepatitis overlap is an area of certain amount of controversy, but it is certainly a clinical entity that exists, but it's quite rare. And there are certain criteria that have been brought up by the Paris PBC group to try and firm up a diagnosis of it. But within that criteria, it's patients that have a diagnostic biopsy forms part of that criteria for diagnosis. The other criteria they specifically say is that you need to have 2 of the 3 of the following things. So that would be an ALT 5 times greater than the upper limit of normal, and or a IgG that's 2 times the upper limit of normal, or a specific anti-smooth muscle antibody. And the other thing is the biopsy that we're consistent with autoimmune hepatitis. And so I think that's the kind of population, if you have a strong suspicion that they have autoimmune hepatitis in conjunction with their PBC, they're the kind of people that I would consider biopsying as well.
Okay, that was really interesting. What about the clinical course of PBC? Are there any specific markers that can help us determine who's more likely to have a more severe disease course?
So yes, most patients at the time of diagnosis don't have evidence of fibrosis when they're diagnosed with PBC. In fact, 90% of patients fall into that category. However, over the following years, and this data to show that over the course of 10 years following diagnosis, 50% of patients will develop symptoms of the disease. And this is evidence of disease progression. And it's not a benign disease because obviously patients with PBC can progress to fibrosis and then subsequently cirrhosis. One of the markers that we worry about is bilirubin, a climbing bilirubin in a patient with liver diseases of concern. And certainly there's been data to suggest that as your bilirubin goes up, the transplant-free survival goes down. So there is a correlation between bilirubin and life expectancy. So that's one of the markers that we'd be concerned about when looking at patients and looking at their prognosis. There are prognostic scores that exist. The UK PBC score is a composite score taking into account lots of different elements of biochemical examination. So your LFTs essentially contribute into that, including your coagulation as well. And it can give you an idea of risk for patients that are on treatment, their likelihood of being transplant free. Previously, people quite often used the Mayo PBC score. The Mayo PBC score was more used in patients with cirrhosis and was more for assessing likelihood of death. So it's more useful in the kind of later stages of disease. So the UK PBC score is something that you can use in patients early on and help to risk stratify those that need kind of more close monitoring and also maybe more aggressive treatment.
Okay, and how should we go about managing these patients?
So I think the BSG guidelines on PBC provide a really useful tool for this. And what they do is once you've confirmed that diagnosis of PBC, you can then go into a 3-pronged strategy for management of PBC. The first strategy is treatment. So it's treatment and risk stratification. And then the other strategies is stage and survey, so establish about patients and whether they have evidence of cirrhosis or not. And the final bit is managing symptoms. And so think about that first section there, which is the treatment section. The treatment of PBC, the mainstay of treatment of PBC is ursodeoxycholic acid. So ursodeoxycholic acid normally makes up 4% of your bile. However, in patients with PBC, when we treat them with ursodeoxycholic acid, we increase the proportion of bile that's made up by ursodeoxycholic acid. And evidence has shown that this then it reduces the biochemical markers, improves the biochemical markers associated with liver disease in PBC. So we know it improves your alkaline phosphatase and your bilirubin. And furthermore, these have been shown to be associated, improvements in your alkaline phosphatase and bilirubin on ursodeoxycholic acid have been shown to lead to an improvement in mortality. So they do have increased survival in patients that are on ursodeoxycholic acid and have an improvement in alkaline phosphatase and their bilirubin. Now, interestingly, the dose that we give is a very specific dose for PBC, and the dose that you should start people on is 13 to 15 milligrams per kilogram. And this dose is given to patients, and initially I'd normally start patients on a split dosing regimen. So I'd have them take that as a total daily dose, split it in two, and then quite often if they tolerate that, then I would end up just letting them have it once a day, so long as it's still tolerable. Certainly when I've previously done audits of PBC, we found that one of the main side effects was gastrointestinal upset that people were complaining of. And the other thing to be wary of is the PIP tablets can be quite big and patients sometimes are not happy taking them. It's important to say with regards to the dose for ursodeoxycholic acid that actually when you give patients lower dose, we see that it doesn't have as significant an effect on their alkaline phosphatase and bilirubin. And furthermore, when you increase the dose, you'd kind of think to yourself, well, can we not give them a higher dose and see if that has any beneficial effect? Studies have actually shown that when you increase the dose higher, that it doesn't have any extra benefit and essentially just increases the number of side effects that people generally get. So ursodeoxycholic acid is the mainstay of treatment, but how do we know that it's working? And that's the important question we need to try and answer when we're treating patients, because if you remember, we need to risk stratify those patients. And so the way we do this is we look at the response to ursodeoxycholic acid, because we know that patients that respond to ursodeoxycholic acid have improved survival compared to those that have a partial response or those patients that haven't been started on ursodeoxycholic acid. And the way we assess the response is after 1 year of therapy, we use criteria. Now, there's lots of different criteria that have been developed over the years and have been tested, but the ones that are recommended in the BSG are the modified Toronto criteria. And so that's if after 1 year of therapy with ursodeoxycholic acid, if your alkaline phosphatase is still greater than 1.67 times the upper limit of normal, or your bilirubin is greater than 2 times the upper limit of normal, then you should be thinking about changing treatment or escalating treatment for those patients.
Okay, and with regards to the ursodeoxycholic acid non-responders, are there any treatment strategies we can employ?
So yes, there are. So there's a licensed drug that we can use in the patients that are non-responders, and we can add this into their ursodeoxycholic acid treatment, and it's called obeticholic acid. It's an FXR agonist, and what it's been shown to do is it's shown to significantly reduce the alkaline phosphatase. Now, we don't have the data for the long-term outcomes for obeticholic acid because it's a relatively new drug, but what we've discussed before is that a reduction in your alkaline phosphatase should lead to an improvement in outcomes for patients. And so we use that as a surrogate. So we can start people on obeticholic acid. And the other thing to say is you have to be wary in patients with cirrhosis. So in patients with Child's B or Child's C cirrhosis, we start with a much more gentle approach. So they start on 5 milligrams once weekly of obeticholic acid. Now, one of the issues with obeticholic acid is the incidence of itch. So up to 70% of patients in the original studies with obeticholic acid were found to develop itch or have worsening of their itch. However, only 1 to 10% of those patients that develop itch need to come off the drug because of the itch. So it's manageable. There is another treatment, although not licensed, which is called bezafibrate. And there was a study done, a placebo-controlled trial done that was published in the New England Journal of Medicine, comparing bezafibrate versus placebo in ursodeoxycholic acid non-responders. And this showed a significant reduction in alkaline phosphatase in patients that were treated with bezafibrate. And it also does have the advantage that bezafibrate doesn't have the same issues with itch. So it's something to potentially be considered, although not licensed, in patients that have itch and have failed on OCA, on obeticholic acid. It's important to say, however, though, that patients that are start on obeticholic acid or on bezafibrate, these should be added into the ursodeoxycholic acid. They're not substitutive. So you continue them on their ursodeoxycholic acid and you add in these other therapies. Unless, of course, the patient's been intolerant of ursodeoxycholic acid.
Okay, so I think we've robustly covered the treatment and a bit about risk assessment. What next?
So I think the thing that you need to do is you need to stage and survey these patients. So you need to establish, are these patients, do they have cirrhosis or advanced fibrosis, the patients you want to keep a closer eye on. And so in those patients, what you need to do is you need to use your traditional markers that you generally use to assess patients with any kind of etiology of liver disease. Ultrasound, so you'll get an idea from the ultrasound of whether there's evidence of cirrhosis. You can use simple markers such as your platelets and albumin as you would, or you can use more complex tests like, for example, using an ELF measurement as a serological marker, biomarker of fibrosis and cirrhosis. And then the other thing that is used widely, and there's a building evidence base for it, is transient elastography to try and assess and establish whether patients have evidence of cirrhosis. And that's important to know because all patients with cirrhosis need surveillance, and the surveillance is the same as for patients with other causes of cirrhosis, so variceal surveillance and HCC surveillance as well. Interestingly, patients with PBC, certain patient subgroups with PBC are increased risk of developing HCC. So they're the patients that are non-responders to treatment, and also the patients that have male patients as well. But there isn't anything in the guidelines to suggest any kind of increased surveillance. So we just stick to patients with a diagnosis of cirrhosis should be having 6-monthly abdominal ultrasound scan and AFP, and their variceal surveillance as per the UK guidelines.
So you mentioned management of symptoms in patients with PBC, and we know that they can suffer from quite debilitating pruritus and fatigue, which are notoriously very challenging to manage in the clinic. Can you give us any specific advice?
Yes, so pruritus and fatigue are very difficult and challenging to manage for patients with PBC. And in fact, interestingly, in patients with PBC, their itch can come on way before they have a rise in their bilirubin. The first line, the management of itch in PBC is actually quite well laid out within the BSG guidelines, and they provide a very useful table to take kind of stepwise approach to management. The first line of management is cholestyramine, and this is as a bile salt sequestrant and helps reduce itch in patients. It's quite difficult to take for patients. One, it's not very pleasant to take, and two, they have to time it so that it doesn't affect their ursodeoxycholic acid. So you have to use that, take it 2 to 4 hours before or after their ursodeoxycholic acid, and it can also affect the absorption of other medications as well. So it's quite a difficult medication to take, not very well tolerated, but can help with certain patients with their itch. The second line after that is rifampicin. So it's been shown to have antipruritic effects in cholestatic liver diseases, but it's not without its complications. There's a risk of rifampicin causing hepatitis, and it can also cause cytopenias as well. So you need to monitor these patients very closely, and it can also affect vitamin K metabolism. So some patients you'll see starting rifampicin will have issues with their coagulation, and that needs to just be borne in mind. They may well need vitamin K supplementation. Then the third line treatments for patients that are failing that are not licensed, as rifampicin isn't licensed for itch as well, and they are essentially an SSRI. So patients can be started on sertraline, which has its CNS effects and affects their perception of itch. Another treatment is naltrexone, and this can be used to reduce the sensation of itch as well. And then finally, the other medicine that patients are started on is gabapentin. And gabapentin is used because it alters your nociceptive and it raises your nociceptive threshold. So patients are less susceptible to feeling that sensation of the itch. Using these kind of third line treatments really is clinician dependent, and they're you know, as they're off license, there's no specific guidance as to which is preferred over another, and they all have varying degrees of success. Moving on to fatigue. Unfortunately, unlike itch, where we've got treatments we can try and offer patients, there's little research has been done into fatigue, and the issue then arises of how do you manage it. Well, you first need to see is it due to something else? These patients are an aging population. Do they have another concomitant disease? Is their itch keeping them awake at night? So maybe treating their itch is something that we can try and do. Do they have concomitant other autoimmune diseases that need to be managed? Have they developed diabetes? There's lots of different possibilities there. And then it's really about trying to develop coping strategies. The important thing to do about fatigue, though, is to try and quantify it, because it's a very difficult thing to quantify. And actually, there's a PBC quality of life questionnaire, which is quite useful to get patients to do, to try and get an idea of their symptoms and try and quantify it, because you need to find out about these symptoms to be able to manage them. And then finally, the other symptom that patients suggest is Zika syndrome. Now, Zika syndrome is something that you'll rarely have patients tell you about. You need to ask about it, and that's dry eyes, dry mouth, and it's something that's very easily resolved, quite often with simple things such as lacrylube or synthetic saliva. But unless you ask about it, patients are unlikely to proffer that as a symptom. So that's another thing that's important to bear in mind. And the final thing you just need to make sure is that you're managing patients' osteoporosis risk because of their increased risk of osteoporosis.
Okay, so bearing in mind the debilitating nature of pruritus and these other symptoms, are there any specific indications for liver transplant in these patients?
So the indications for liver transplant in patients with PBC in the cirrhotic population is the same as for other cirrhotic patients. So it is when they have a UCAL greater than or equal to 49. And their patients should be are eligible to be referred for liver transplantation. Certainly the guidelines would suggest that patients who have a bilirubin of greater than 50, you should be thinking about referring them to a transplant centre, or at least opening discussions with a transplant centre at that point. However, there is an ability to list patients for transplant that don't have cirrhosis, and one of the indications for this is pruritus. So patients with debilitating pruritus that's gone through all the treatment options and potentially tried other treatment options as well, experimental treatment options, can be potentially referred for listing on the variant list for liver transplantation.
Okay, excellent. And finally, do you have any top tips for us when we're coming to review a patient with PBC in the clinic?
So I think the one thing that I learned from doing the PBC audit was both locally and then feeding into the national audit, was the importance of documenting all the different features that we've discussed today. So what I aim to do before a patient comes into the room is I want to find out what their liver function test's doing, what medication are they on, are they at a appropriate dose of ursodeoxycholic acid, so has their weight changed? Because patients gain weight, they lose weight, things might have changed since they were starting ursodeoxycholic acid, so you want to make sure these patients get a weight before they come and see you. And then you want to make sure they've had their risk stratification done. From that point of view, have they responded to their ursodeoxycholic acid? It's important to document all these things as well. Have they had a stage and survey done? Do they have cirrhosis? Do they need surveillance from a cirrhosis point of view? And then I think that leads you to have the patients coming into the room, and when they come into the room, you're armed with all of that, and you can then focus on their symptoms, because what affects patients the most are their symptoms, and that's what their concerns are about. They want to know how you can manage their itch. They want to know what you can do for their fatigue. They want to know about their Zika syndrome as well. So I think that's a useful way is to use the PBC audit tool, which kind of ticks off all these boxes in your head, and think, if I was going back to look at this, would I want to make sure that all these things have been documented and that I've gone through and asked specifically about them all?
Excellent, thank you very much. That was a fantastic overview of primary biliary cholangitis. Thank you very much for your time. And that just leaves me to thank you for watching Digest This.